of those 30 people, 28 people eventually developed symptoms of COVID-19. What's important to know is that of those people, there was no direct touching of items or articles. We were practicing hand washing techniques. We were practicing hand sanitizer. We weren't practicing social distancing. We were breathing the same air in a room that clearly was ventilated and was broad. However, by breathing in this same air, it lets me know that this is a respiratory pathogen, and that breathing can expose other people to it. And if you're within a 1 to 2 feet periphery on somebody with just regular breaths or conversations, you have an increased likelihood of getting the virus. So also, if you're in a room with somebody with COVID-19 and they sneeze, if you're in a room with somebody and they cough, those respiratory droplets will spread across the room as far as 100 feet away, and you will be exposed to COVID-19. So again, one of the things I wanted to talk about, probable date of infection, was March 13th. So on March 13th to the 16th, these were the days that I was exposed to the virus along with approximately 25 additional people. The mode of transmission, respiratory. I'm absolutely positive that this virus is spread through the air. So what that means is we can do all the hand washing we want, we can do all the sanitizing without appropriate social distancing and without blocking the spread of the virus through the respiratory pathway. You have a high risk of getting the disease. And the outcome was there were only 8 people tested. 8 out of 30 people were tested. We went to hospitals, we went to clinics, we went to all different types of venues in an attempt to find out if we could get a positive test. I wasn't tested. I called, I requested a test. I was told I didn't fit the high risk categories, therefore I wouldn't receive a test. The only people out of the group that received the test were individuals who presented to a hospital institution and were either admitted through the ER or admitted to the hospital and were later released as a result of not having the morbid symptoms. Out of these 30 people, nobody was hospitalized and intubated, which is an excellent thing. One of the things I wanted to talk about is symptom onset. We were exposed March 13th to the 16th, and the majority of the people that developed symptoms didn't develop symptoms until March 20th or 21st or later. This is like 5 to 8 days after the exposure. So that meant that for 5 to 8 days, the majority of us who had been exposed to COVID-19 were walking around in the community amongst our loved ones and amongst our employees and our friends, and we were probably actively spreading the virus. So you had, in this one group, you had approximately 30 people who clearly had been exposed or infected with COVID-19 who were walking around and who were asymptomatic. That's important to understand in terms of the spread of the virus. Let's talk about its potential exposures. Most common virology or the study of viruses shows that for every person infected, they probably infect 4 other people. And then those people probably infect 4 other people, and so on and so on. But with this virus, I think that those numbers aren't accurate, especially when you're dealing with what's called a novel virus. What is a novel virus? A novel virus just means new. It's a new virus, and as a new virus, we got 330 million Americans. And of those 330 million, no immunity. There's no herd immunity. There's no community immunity. That means that all 330 million people are eligible to be infected with the virus. And then we're going to talk about later how that impacts the spread of the virus through a community. Let's talk about symptoms. The symptoms of, first of all, let's go back to infected persons and how they dealt with the community. Before I recognized that I was infected with COVID, and again, I have never had a confirmative test. What's the importance of that? Do you need a test to know that you had COVID-19? No, you don't. If you've been in a symptom situation where you're around people who have been impacted by the virus, if you know that people in your group have tested positive and you come down with what we call a viral syndrome. What is a viral syndrome? When you get infected with a virus, you're going to have a group of symptoms that we call the viral syndrome. What is the viral syndrome? Fever, chills, sweats, rigors, or shakes. You can also have diffuse body aches and pain. What was my symptom presentation? The first thing I experienced was a slight chill. Wasn't an overwhelming chill, wasn't a chill that made me bedridden, but I knew something was going on, and this was on Saturday, the 21st. Now I'm gonna tell you later about the interesting, because I traveled during this whole period. And while I was traveling, I'm sure that even though I was practicing social distancing, because the guidelines continued to evolve over that time, I clearly were in environments where if other people had not been infected, I put them at risk unknowingly. And I'm sorry, but that's just how this thing goes. My symptoms went from slight chills to a very low-grade fever over the next 8 days. I also had sweats, primarily at night, and I could actually feel the virus in my body. I had scalp tenderness, skin tenderness. I had diffuse body aches. The diffuse body aches dissipated over the first couple of days, but there was a persistent intermittent fever, chills, and sweats. At that point, I never developed respiratory symptoms, and so thankfully I was never feeling as if I was at risk for those advanced respiratory distress type of pictures that we see with people who end up on ventilators. Okay? The symptoms resolved on March 31st, and by April 1st, I felt absolutely normal. Today, went out, did my workout, I feel fine. I feel like I've overcome the virus and my immune system kicked in and gave me immunity. Now, let's look at some overarching views. We got something going on these days called mitigation. You all bear with me because I don't have my support team with me because we all in social distancing and isolation. And forget the phones and the other things because I'm at work. I work in the healthcare industry. We are one of those essential employees. So again, let me talk about the travel piece though. That's really important. From March 15th through the 21st, I went from O'Hare Airport to Miami Airport, flew from Miami Airport into Puerto Plata Airport, and then drove to Santiago and met with my cigar distributors because I have a cigar company. I met with them. We met briefly. I found out my flight home had been canceled, so I went directly to and everything in the Caribbean has been on lockdown since around March 14th. So there's nothing, you can't move around normally. So it's not like people are going around at the beach, at bars and stuff. None of that. All that's been locked down. I left. I went to my hotel room, called JetBlue, got the last flight out the city. During that time period, it's doubtful that I impacted any people because I was isolated almost the entire time from O'Hare to Miami to Puerto Plata to Santiago. I had a few contacts, came back to Puerto Plata, flew out on Saturday. Saturday, when I got into the airport at Boston, I started feeling like maybe I had contracted something, and then I started getting word from my people here in the city that people that were in my group had started testing positive for COVID-19. So I knew I had been exposed. It fit the timeline of 5 to 8 days, and I started being symptomatic. I immediately went to extreme social distancing and isolation. You know, when I was on the plane, I sat in the back. I got set away from people. I had a mask on, and I just hunkered down, and I was doing my best to quarantine myself. I got home. I went into my bedroom. I shut down the house. I stayed upstairs. The kids stayed downstairs. Food at the door. And I started trying to take care of myself and keep my family from being infected, and nobody else has come down with any symptoms. So now we're going to talk about mitigation. By now, some of you have seen this graph. What the graph, basically, this is number of infections. And I hope you all can hear me. And this is time. And as you all know about graphs, the graph went somewhat like this, and then it peaked up, and then it dropped off. And then there was another graph that went more like this on top of it. And the reasoning behind this was to say that we want the number of infections to not peak at this time, but to level off. And so that we never get to this threshold, beyond this threshold that will overwhelm the healthcare system. What people need to understand about what this graph is telling you, because everybody's going into shutdown mode, viral spread prevention mode, and it's with an idea of somehow that you're going to be able to escape getting infected with this virus. But we got 330 million Americans and we got no immunity. So what's the possibility of us keeping this virus from spreading through the community? Is not very good. And by my thoughts is that probably 80% of the country at some time in the next 6 to 12 months is going to get infected with COVID-19. What do you do with that information? Let's look at the graph. We're not going to, the area beneath this graph and the area beneath this curve and the area beneath this curve, it's the same number of people getting infected. The only difference is time. So if the same number of people are going to get infected, how reasonable is it to think that you're not going to be one of those people? Let's look at some numbers. Right now they're saying that 250,000, right now they're saying 250,000 Americans, that's 250K, have a confirmed diagnosis of COVID-19. That's confirmed. What that means is that they had a test for the virus. The test came back positive. And remember, the testing that's being done now for COVID-19 is on virology. It's on the actual virus. But a more accurate test that'll tell us more about who's been infected is going to be an antibody test. The COVID-19 antibody test is just now approved, and most people have not had this test. What it proves is that you had an active infection and that you developed antibodies to the virus, and that you are now probably have developed in a level of immunity. A more accurate number is, you got to look at how is it a more accurate number. Only 5%, my estimate is 5% of people are actually being tested who are being infected. And how do I come by that number? These 5% represents the people that present themselves to a hospital, institution, or emergency room with symptoms that are profound enough to warrant an a viral test or warrant a COVID-19 test. So if this 5% of the people, that means that 95% of the people who have symptoms of COVID-19 are not being tested because they don't have morbid enough symptoms to warrant the test. They don't have respiratory distress. They just have fever, some chills, some sweat, some body aches. They had a viral syndrome and they're sent home and they're told to quarantine for 14 days. So if we're looking at 250 people representing this 5% of people who had a positive test, what that's telling us is that 95% of the people, and so by a factor of 9.5, we know that they're probably 9.5 times more than this 250K. So that means that we're looking at about 2 million people in this country or more, 2 million, who probably are infected with this virus. That's 2 million out of a potential 330 million. If we were to use an equation to estimate the number of people who possibly had COVID-19, it would be 250 confirmed cases times a factor of 9 over 9.5. And then there might need to be some other factor that we would include, because these 2 million people have possibly infected another, every one of them infected the factor of 4, and say within the first days of the virus by a factor of 4, but you're supposed to multiply that factor every day by an exponential factor of 4. So it could be anywhere from 8 million to a factor of, over those number of days, that could be exponentially large. My estimate is that we're somewhere between 2 million and 8 million infections in America. And still, 2 million and 8 million is nowhere near 330 million. We have over 300 million people that have not been impacted by the virus and who have now become possible hosts for this virus to remain in the community. Let's look at some timelines, because this is really important. We're on quarantining, we're on social distancing. They're telling people to stay home, right? So the timeline now is April 30th. Today is April 3rd, right? So for the next 4 weeks, we got 4 more weeks of social isolation. What's going to happen in 4 weeks? We've mitigated the curve. We've got the number of infections down, but the total number of people infected in the timeline has been reduced significantly. We didn't get this huge spike of infections, but we know that there are a large number of people who have been impacted by the virus. My estimate again is 8 million. And how have those 8 million people spread the virus around in the community? In 4 weeks, we're going to see an explosion of the virus, and we know that over the next 4 weeks. The first 2 weeks are going to be the most critical. So suppose we get around that 8 million total number of infections. When the quarantine stops on April 30th, if we resume normal activity, as soon as you leave your houses, as soon as you leave the environment that you're in quarantining and you go out into the community, you're going to immediately people are going to be exposed to the virus all over again. The isolation is not going to stop what I call viral outliers from being infected. Police officers are going to continue to get infected, paramedics, doctors, nurses, delivery drivers, anybody that's actively in the community and exposed to the virus. So if you stop the quarantine on April 30th, it's not going to, and you go back to normal activity, that's not going to stop people from getting infected. People are going to go right back into an exposure. Remember, we got 300 plus million people that still have not been exposed to the virus. What's going to happen is we're going to start the pattern all over again, where we're going to get right back into the graph. We're going to see this rise, and we're going to have to start mitigation again to keep the numbers down so that we don't overwhelm the healthcare industry. Let's go into some other. So what will mitigation accomplish? Let's go back to that. What mitigation will accomplish is keeping the total number of infections down to a point where the medical community can handle the number of people that get into this 5% hospitalization rate. Those people that come up with this, with the catastrophic respiratory distress requiring ventilation and the overwhelming of the hospital system. And that's what we're trying to prevent. Another question is coming up is one about testing. And as I said earlier, what is getting a test for COVID-19 going to change your outcome? It's not. You have to assume that you had COVID-19. You can get tested anytime. If you don't develop respiratory distress and you're just sick, you can sit down for 14 days. You can quarantine and you can protect your family members and the people around you, and you can assume you had the virus. So it's really hyperbole, so to speak, that people are talking about the necessity for testing. Testing is not going to change the outcome of the disease. It's going to tell you whether or not you have it, but there are no other viral syndromes in America right now that's having this impact. So 98%, 99% of people who are coming down with a viral syndrome of fevers and chills, sweats, body ache, you got to assume that you got COVID-19. And if you do, quarantine yourself, protect your family, sit down for 14 days and wait for the viral syndrome to resolve. And again, those numbers of COVID-19, I'm guaranteeing you that in the next 4 weeks, they're going to start showing that the actual number of COVID-19 infections based on antibody testing and based on statistics is more likely 20 times higher, 10 to 20 times higher than the numbers that we're seeing projected from the actual numbers. Let me go into a little bit more of this information. Here we go. Again, we talked about COVID-19 spread. It's more than likely we're going to find that this infection is spread primarily through breathing, through respiratory droplets, through talking, and through coughing and sneezing. Is 6 feet enough? I don't believe it's enough, because if people are sneezing, if they have an active virus, if they're coughing, those particles are going way beyond 6 feet. If 6 feet is a good start, we're going to need a greater degree of social isolation. Another question is, do masks work? I'm not sure that a mask will protect you from respiratory droplets unless you have one of the high-tech masks and you're wearing one of the shields over your eyes and protecting your mucous membranes, the mouth, the nose, and in the eyes, that the virus will come into your body through. Unless you have that high level of protection, if you're in a room with somebody who has COVID-19, they're coughing, they're sneezing, they're breathing, they're talking, you're at a high risk for infection, and whether you have a mask on or not is not going to make a great difference. What more likely can happen with a mask that people aren't really looking at is the mask can become a focus of viral particles if you have the virus, or if the virus is in the area and it touches the mask, then the mask becomes a fomite is what we call it in medicine, meaning that it can take the bacteria, the viral particles, and they can be concentrated on the mask, and that's not a good thing. Okay, let's talk about symptoms of COVID-19. Fever, sore throat, dry cough. I'm just going to talk about it. I'm not going to write it on the board. Most people with COVID-19 present with these aspects that I talked about earlier of the viral syndrome. The viral syndrome is going to have fever, you're going to have chills, and you're going to have sweats. But with this particular virus, most people are presenting with a dry cough and a sore throat. Out of the 30 people that were in the group with me who were impacted, everybody complained at some point of having a sore throat and having a dry cough. Also, I talked about the chills and sweats. One of the symptoms that people are discussing is the loss of taste and smell. One of my fraternity brothers called me up. He said, man, I can't smell anything or taste anything. He later developed more profound symptoms, but his primary symptom was the loss of taste and smell, and we're seeing that. GI symptoms. The day before I developed the fever and the chills related to the COVID-19 infection, I had a gastritis like I had never had in my life. The pain was severe, and I'm sure that these GI symptom presentations are a part of the infectious process and one of those presenting symptoms. And so if you having any type of GI distress, that may be an indication of infection. We talked about body aches and we talked about the viral syndrome. Now, here's an important piece that I want to talk about. People are saying, why are people dying of COVID-19? And what I've learned by watching and discussing is there are 3 groups of people who are coming down with these overwhelming infections and are dying from COVID-19. Let's talk about that for a minute. The first one I want to talk about is underlying medical conditions. Underlying conditions. With these underlying conditions, we're talking about diabetes, hypertension, congestive heart failure, chronic kidney disease, COPD or asthma, any type of respiratory lung disease. People with these illnesses have underlying conditions, and for reasons that aren't totally clear, except that these conditions impact a person's immunity or immune system, these people are more likely to develop the profound and chronic respiratory distress that we see in this illness. There's also another group of people. Just as these underlying conditions will give you immune suppression, anybody with a suppressed immune system. What do I mean by that? I hope I'm spelling this right. Anything that suppresses your immunity. This could be medication, asthmatics, people with any autoimmune disorder are often taking medications that suppress the immune system. You got a group of medications called biologics that are out now. These are a group of medications that slightly to suppress the immune system so that people with autoimmune disorders will not have the body reacting in the way it has. But the good thing about it is that it will treat the immune disorder, but also it suppresses the immunity that makes you more likely to get an overwhelming COVID-19 infection. Okay? Also, anybody that doesn't have a functional spleen, like people with sickle cell who have something called an autoinfarct of the spleen, where the spleen actually loses its blood supply and the spleen dies and you don't have a functional spleen. The spleen is responsible for clearing infection from the body, bacterial and viral. And if you don't have a functioning spleen, if you lost it through an accident, had it removed, or had a disease where you just don't have a functional spleen, you're at increased risk because of suppressed immunity. Now, here's the last one. So anything that suppresses the immunity. But the last one is what we call exaggerated immune response. And what's happening for unknown reasons, and this is where you get those outliers. People who are relatively healthy, and all of a sudden they come down with the infection, and the next thing they're having acute respiratory distress. These people are having an exaggerated immune response. What occurs in this condition is that their body mounts an immune response that is so inflammatory and so enlarged that eventually the lungs shut down due to this inflammatory response, and it shows up like a pneumonia. It's not a bacterial pneumonia, and it may not be a viral pneumonia. It just may be a pneumonia due to the inflammation that's in the lungs. And these people develop a fibrosis in their lungs, and they eventually succumb because they can't get appropriate oxygenation through the lungs. Now, we're going to be wrapping this up, but I want to give you a little bit more information. One of the things that we're talking about is ventilatory support. You've been hearing a lot of people talk about ventilatory support, ventilators. There's some facts about this that people got to know because it'll help you understand. It's going to help you understand all of this conversation about ventilators, ventilatory support, the need for 30,000 ventilators in New York, how we don't have enough ventilators. The first question you got to ask you is, when a person gets to the acute respiratory distress requiring ventilatory support in this disease, how many people that require a ventilator get off the ventilator and walk out the hospital healed from COVID-19? And that number is approximately 20%. So 20% of people who require ventilatory support are going to eventually get off the ventilator. That means that 80% of the people requiring ventilatory support die from COVID-19. That's a large number of people. When you get into that 5% of people that require hospitalization and treatment, and then of those 5% that go on to require ventilatory support, 80% of them die. That's an overwhelming, taxing impact on the healthcare community treating these people. And so, if as leadership has to make decisions about how significant that is, because the truth of the matter is, what this is saying is that once you get to a point in this disease where your lung function is decreased to the point that you require a ventilator, you got an 80% chance of dying from this disease. Those are overwhelming numbers, and you can extrapolate that any way you want to come up with a conclusion about what that means to our country. So, again, 5% of people are requiring hospitalization. Maybe 20% of those people go on to require ventilatory support. When you're talking about 330 million Americans, and you're talking about possibly 200 million Americans becoming infected with COVID-19, with a 5% hospital rate, you're looking at 5% of 200 million is like 10 million people, correct? So if 10 million people require hospital support and care because of COVID-19 at some time in the next 6 to 12 months, and of those people, 5% end up requiring a ventilator, we're talking about somewhere in the tune of anywhere from 1 to 4 million people possibly requiring a ventilator to care for them during this time. And then 80% of them are going to die whether you give them treatment with the ventilator or not. This is the kind of information that our government leaders already have access to. So they understand the impact of what's going on in our country with COVID-19. And so it may seem callous and it may seem cold, but when you're looking at raw data like that from your actuaries and the other people that sit up and look at the epidemiological numbers, they're already assessing a certain number of people, whether we treat them or not, are going to die from this disease. Okay? not sure how helpful that was. I'm grateful to God that my exposure to COVID-19 and infection with COVID-19 didn't kill me, didn't leave me debilitated, didn't leave me with lung disease, and that I can stand before you today in an excellent state of health and having recovered from it. There's got to be strategies that we look at moving forward. And in the words of Steve Harvey, you all know that I'm a black man. I serve the black community. Most of my friends who are physicians are black. They serve the black community. Most of the nurses I know, we serve the community. Steve Harvey said it best. We black out here. We different. We have this disease is having a different impact on our community. I'm seeing an inordinate number of African Americans and American descendants of slaves, people who have an ancestral lineage in this country, dying from COVID-19. And as I look at the news reports and I look at the things that I'm seeing trending, I'm seeing large numbers, 30-40% of the people that are succumbing to the disease are black people who have underlying illnesses, who have immune suppressing diseases, or who are having this exaggerated immune response that's leading to these deaths. That's really significant. There are a couple of strategies that I think will help our community with this. And the first one is all high-risk people. If you're at high risk of developing this infection, if you're at high risk, you need to quarantine. And the quarantine is a word used. Sequester is a word used. Isolation. We need to do everything we can. We need to do everything we can to isolate any high-risk person. People over 60, if you don't have to go out, if you don't have to be exposed, isolate. If you're older than 60, even more so. If you have diabetes, high blood pressure, congestive heart failure, COPD, asthma, isolate. Anybody that knows that you have those risks, you need to isolate. Here's another strategy. We need to do advanced antibody testing for COVID and find out who's been exposed and who's developed an active immunity to the disease. Those are people who can be in the community working, fighting to keep we're the people who can go into the senior residences. We're the people that are going to be able to not infect other people because we've already mounted an immune response. So we can actively go back into the workforce. The government has got to work hard to find out who these people are. I know people that have called me since this event occurred who are telling me that they had symptoms of COVID going all the way back to November 2019. I know people that their symptoms and their presentation suggest that this virus has been around for at least 5 months. We need all this antibody testing done so we can find out who in the community has an active immunity and who can return to work. The other issue, and those are those two strategies I think will help us a lot. Isolate, quarantine, and sequester our at-risk populations. Get people who are already immune to the disease back to work. And the other piece is it's a roll of your dice. If we know that possibly 200 to 250 million Americans are going to be infected with the virus, if we isolate or quarantine all the high-risk people, that means that we can allow more people to enter back into a normal life with the precautions that we're using to prevent infection. If these people become infected, they're not in that high-risk category. We can do that and pray that they don't develop an extreme immune response and succumb to the virus. But to keep people isolated for months and months and months on end, that's not going to be a solution, because when isolation ends, we're going right back to these curves. People are going to be infected because the virus is still in the community, and the virus is going to remain in the community until we get a more well-established herd immunity or group immunity that only can come through people getting infected. That's a harsh reality. And I'm not sure what other directions or what other means that we can take for fighting this. That's all I really got for you all today. If you got questions, hit me on Facebook Live or hit me on Facebook. You all know my number. You all have me on Instant Messenger. Hit me up with any information. I'm going to give you an update by next Friday and do the best job that I can to continue informing the public. Thank you. My name is Ken Nave, and I'm out.